Hi class, welcome again to another session on rehabilitation engineering. Today we're going to study about handicaps, diagnosis of disability, disability evaluation and functional diagnosis. So let's crack on with the lecture. So according to WHO or the World Health Organization, handicaps are of six types. Locomotor handicap, which means people who cannot move very well, visual handicap, hearing and speech handicap, cardiopulmonary handicap, intellectual handicap, emotionally disturbed handicap. So locomotor, like I said, are people who handicaps are people who have issues with moving, right? If they're wheelchair bound and if certain places are not accessible to them, so in those places they become locomotor handicaps. Visual handicaps are people who have issues with their vision. Colorblind people, for example, cannot visualize the traffic signals very well, and therefore driving becomes a handicap for them. Hearing and speech handicap, one a hearing handicap, of course, you all know about people having using the cochlear implant or hearing aid. Speech handicap can occur over a period of time. If someone has had a stroke, then their vocal cords are not innervated properly, so that can lead to speech impairment, either dysphagia or dysarthria. Cardiopulmonary handicap can be, if you have breathlessness and or when you go high up in the altitude, then that could be cardiopulmonary handicap because if you're someone who loves mountain climbing but can't take out all, but can't be normal with high altitude, then that makes you a cardiopulmonary handicap. So intellectual handicap, usually people with Parkinson's, cannot think on their own. Their cognitive thinking ability is affected. So intellectually, they can't take a decision on their own. So they become intellectually handicapped. Emotionally disturbed. All of us know, like people who have, emotional issues because of some other handicap. So many people they have multiple handicaps. I mean, it could be very well just one handicap, or it could be emotional plus anything else, or a combination of all these six handicaps. And people with more than one handicap should actually be treated very, very delicately. So diagnosis of disability is like a disabled person should be evaluated early and intensive treatment should be provided as early as possible to avoid permanent disability. So, physical, emotional, vocational, societal status of a person should be considered while diagnosing their disability. So, a disabled person should be treated as a fellow human and not as a case because, sympathy is the last thing a disabled person wants. He or she would want to be treated as just another human being. And, they're just a human being with some impairment, that's it. Some things they can't do as well as we can. So that's why, people with disability should be treated as human. They should be treated just as a case. Now, diagnosis of disability can either be disability evaluation or functional diagnosis. So, disability evaluation is actually the extent of disability, and functional diagnosis is the residual function that is left, which could be utilized to improve their ability to perform tasks. So the quantum of disability evaluation varies according to the methods that are used. You can use a chart or you can give them a score. Say, their hand function is 50% of the normal value, or you know, for a stroke person or a person with Parkinson's or cerebral palsy, their fear of falling is 8 out of in a chart of 10, where 0 is minimum fear and 10 is maximum. Then you can have certain grades, like it's just given as a number, the disability, like you have various outcome measures. Again, you just don't use one outcome measure to come to a conclusion. You have to do a series of tests, and these tests for each and every disorder are given in certain guidelines associated with that disability. Now you have the WHO guidelines for various disabilities. You have the NICE guidelines for various disability and so on. So these guidelines basically give you an idea of what all tests you should be doing before coming to a conclusion. So, based on these tests, each test would give them a particular score, and based on that score, you evaluate their disability. So, it also helps in identifying the extent of handicap in a person in order to make him or her eligible for certain concessions offered by the government from time to time. So, if someone wants to claim disability allowances, then these scores of disability evaluation can help them get their benefits. So functional diagnosis basically is diagnosing the residual functions. Now, what happens is, okay, you have a person whose arm is 50% disabled. So the remaining 50%, what all muscles are working and how well those muscles are working. Is there anything that we as a rehabilitation engineer can do to improve the function of the muscle? Or is there any method through which we can use the residual function and enhance the person's ability to perform certain tasks, which would give them some independence? So, functional diagnosis should be A, objective, because it should be measurable. There should be a statistical significance to whatever measurement we do. It should be descriptive, because the actual situation should be accurately reflected. If a person has stroke and he or she can do only certain functions, then description of those certain functions should be very, very crisp in your functional diagnosis. So it should be simple enough so that rapid evaluation is possible. You don't want a functional diagnosis method that uses 10 different long formulas and you sit in front of the patient with your calculator and keep on calculating to get the results. No, that's not what we want. We want something that is very, very quick to evaluate, because a rehabilitation clinician will have n number of patients to review on a particular day. So they can't just spend too much time in calculations. They just want rapid evaluation. It should be reproduced. What reproducible. I mean, similar to medical devices, basically, it should be consistent. It shouldn't be the variation in calculations or the variations in the diagnosis should not be too much. At the same time, it should not be an iffy diagnosis either. So, lastly, a functional diagnosis should be very, very comprehensive in the sense that it should consider all possible aspects of a person's disability and then come to a proper conclusion. Like I said, it should not be just one or two tests which would lead to the clinician concluding that ABC has got XYZ ailment. It should be a very, very comprehensive method of diagnosis. Occasionally, patients will have more than one disability, and such patients should be handled very, very sensibly. For example, a child with cerebral palsy can also have hearing and visual impairment along with physical disability. So, occasionally, I mean, able-bodied people like you and I have issues with our temperament. Occasionally, we are frustrated and we just vent out. But these children, they are having a disability. Whatever is there in their mind, they're not able to communicate properly or they're not able to visualize whatever they want to see. So such patients get frustrated and they, because of their condition, and they end up throwing tantrums and do not cooperate with the therapist. So as a therapist, you have to be very, very patient with such such people, and then you have to identify a particular activity that calms this person down, and after calming them down, try the therapy again and maybe they will cooperate. So this is just a job of patience and perseverance. Primary and secondary disabilities is going to be the last topic that we discuss in this session. So, primary disability is the direct consequence of a particular disease or disorder. For example, paralysis as a result of spinal cord injury or stroke. So, if a person has had a stroke or suffered a neck fracture or spinal cord injury, then direct consequence of that particular injury or incidence is paralysis. Secondary disabilities, however, are consequences of the primary disability. They develop subsequently over a period of time. For example, pressure sores on a person who's constantly on the bed. Now, the now a person who's paraplegic is always seated on a wheelchair or is lying down. So that can result in pressure sores. Another example is shoulder subluxation in a stroke patient. Now, due to stroke, the muscles of the affected arm are not used at all or are used minimally. So this results in muscle atrophy, and when muscle starts to atrophy, it weakens. So that would weaken the shoulder joint of the affected side. So this would result in the shoulder slightly lowering from its actual position. Now, that is a very, very painful situation. At the same time, over a period of time, the shoulder gets weaker and weaker and weaker. So this actually results in more subluxation, and that would result in modification of the patient's posture. So posture modification would result in overcompensation by other working muscles, and that would result in you know, fatigue and pain in other sections of the body. Now, immobilization due to whatever cause has got a major impact on the disability, and many patients encounter a lot of issues with the secondary effects of disability. Now, disuse atrophy of the muscle is one of the most commonly observed impact of immobilization. The muscles atrophy very, very rapidly, and then bringing back an atrophied muscle to health is is an uphill task. I think that's all we have time in this lecture. I shall see you again in another one. Thank you very much.